Hello, hello. Welcome, everyone. Thank you so much for joining us today. My name is Kevin Schott. I am the Director of Engagement at the ADOS LGBTQ plus Health Initiative at the University of Pennsylvania School of Nursing. So glad to have you here today for this great conversation. I don't want to take up too much time, so I'm going to go ahead and share a short presentation as people filter into the webinar space and tell you a little bit about ADOS and the conversation that we are going to be having today. So as I said, I'm really excited to be talking today for our talk, Advancing Intersex Health Across Fields. I have to say that I think we've done a really great job assembling a team of interesting panelists who have made impactful work and are committed to really improving the lives and well-being of intersex people. I'm excited to let you hear from them in a moment, but before I do, I wanted to say a little bit about ADOS and why we work to create spaces like this for experts from different sectors to speak to one another. At ADOS, we describe ourselves as a social innovation hub, advancing LGBTQ plus health. And that word innovation is really intentional for us because we believe that the transformative changes needed to improve health outcomes require new connections and collaborations that go across industries, sectors, and lived experiences. We believe that knowledge and great work too easily have been trapped in silos and unable to spread out to the people in our whole field. So we bring together researchers, clinicians, technologists, community organizations, and create space to imagine and create new solutions that are grounded in science and equity. Our commitment is then to move from these conversations to real life products and processes that people can use. Today, we're going to be talking about intersex health. And so I want to say a little bit about the background on this topic for those of you who might not be as familiar. I'll also confess now and say I am not the intersex health expert in this space. Those will be our panelists who will introduce, but I wanted to preface the conversation with a few comments that orient us. And I promised them all the opportunity to read me for filth if I say anything wrong or to correct any misconceptions that I might make along the way. So first things first, what does it mean to be intersex? Intersex is an umbrella term for people born with innate variations of sex characteristics. So things like chromosomes, hormones, and anatomy that don't align with the kind of typical expectations for male and female bodies. These variations are natural and normal, and there's over 40 different variations that have been documented. It's also important to note here that intersex people aren't incredibly rare. It's about 2% of the population, which is about the same prevalence as natural redheads in the world. But even though being intersex isn't super rare, issues around intersex health have been widely misunderstood, very underrepresented, and in many cases erased from medical education and practice. Because of these misunderstandings, intersex people often face preventable health challenges. Far too many have undergone non-consensual surgeries to correct and normalize bodies that were already healthy. These surgeries continue today and are often upheld and even reinforced by the recent legislative bans on gender-affirming care. Intersex people also report frequent difficulty accessing providers who are informed about their health, affirming of their identities, and competent to treat them. Outside of clinical settings, they encounter family rejection, bullying in schools, and social stigma at higher rates than other communities. Many struggle to obtain ID documents that are correct and reflect who they are. And all these experiences take a measurable toll on their health and their bodies. These disparities exist within the even wider world of LGBTQ plus health disparities. And I want to mention here that being intersex is not a sexual orientation or a gender identity. An intersex person may or may not be gay, bi, trans, cis, but they face similar health challenges as these groups. A 2020 national survey found that 88% of the LGBTQ plus intersex people reported discrimination by a doctor or healthcare provider, far higher than the non-intersex respondents. And when asked about daily functioning, the ability to go about like normal tasks, the intersex respondents were also more likely to say that poor physical health kept them from just usual activities, going out, going to work, spending time with friends, recreation, self-care. This tells us something really crucial. Intersex health is an LGBTQ health issue, but one that has been overlooked And as a result, there has been an underinvestment in the health of intersex people. At ADOS, we often point out that this underinvestment can be seen in every sector we look at. So, for example, within the NIH portfolio, less than 1% of funded projects focus on populations that are LGBTQ+, and an even smaller percentage goes to those of intersex people. Looking at private philanthropy, for every $100 spent, only 20 cents goes to any kind of LGBTQ plus cause. And looking at the startup ecosystem, one of the most innovative spaces creating new solutions to entrenched problems, only 0.5% of the 2.1 trillion invested reaches LGBTQ plus entrepreneurs. These gaps matter because when communities aren't resourced, their needs remain unmet and their health inevitably suffers. At ADOS, we believe that this can change even in these systemic headwinds. As our founder, Dr. Jose Bauermeister, has said, community experiences, diverse partnerships, thought leaders, and public health science can join together to advance the health and well-being of the LGBTQ plus community, and that includes intersex people. Our belief is that by grounding our efforts in community voices, recognizing movement leaders, and bringing together sectors that don't always sit at the same table, we can build new solutions that are equitable, evidence-based, and truly innovative. So today's conversation is about more than just learning. It's about a chance to connect and to start collaborations and to imagine what's possible when we commit to really addressing entrenched problems. So I would like to thank our panelists before we even start, just for being part of this work and for bringing their expertise, creativity, and commitment to a future where intersex people can thrive as they deserve. So with that, I'm going to stop sharing my screen and give a chance for the panelists to introduce themselves. I always hate doing introductions for people because I'm sure I'll forget something very important to them or not mention all that they do. So I'm going to call on you one at a time to introduce yourselves, say a little bit about your work with intersex health, and also one thing in your work that's currently going well. I'm going to start with Katie, if you wouldn't mind unmuting and introducing yourself.
Sure. Thanks so much, Kevin. It's really just like thrilling to be here, having this conversation with you and with three people who I just love and admire so much on a personal and professional basis. My name is Katie Dalke. I am a psychiatrist at the University of Pennsylvania. I'm an associate professor of clinical psychiatry. I also have a leadership role in the department in clinical operations. And I have been involved in intersex advocacy, support and education for actually this is my 20-year anniversary this year from my like official coming out. Um, I come to this work as a person who grew up with an intersex variation, who experienced some really fabulous medical and mental health care, and also some really troubling and painful medical and mental health care. The big turning point for me personally was getting connected with a support organization in the 90s, which really, back in the day of Yahoo groups, um, really made a huge difference for me in figuring out who I was and starting to kind of tell my own story. Through that work is really where I connected with a deep and abiding sense of purpose to do everything I could, in particular to make healthcare safer and more effective for intersex folks. And the way that I approach that right now is in my clinical work as a psychiatrist working with folks who are intersex and have mental health needs, as well as with other LGBTQ groups, and getting engaged in research that focuses specifically on some of the social and structural determinants that you heard Kevin acknowledge that really seem to make a big difference in our ability to thrive and be well and be healthy. So I sometimes think that like the the sort of caption for my professional work is really like intersex people, we're more than just our genitals. So
And can you say something that's been going well in your work lately?
Oh, yes. I am really going to embarrass him, but I'm going to say that SJ, actually working with him, has been something that's been going really well. In my work recently, you'll hear a lot more about what SJ is up to, but it is incredibly gratifying to work with new folks coming up who are thinking about these problems in really exciting and creative ways, and giving me a sense of hope, for the future that honestly I haven't had in a minute.
I love that. And it's also the perfect transition because due to the tyranny of the alphabet, the next person to introduce themselves will be SJ. So I'm going to invite you to unmute yourself. Tell us a little bit about yourself and your work in intersex health, and then something that's going well right now for you.
All right. Well, all, thank you for such kind words, Dr. So I'll go ahead and introduce myself. My name is Si-Jin, but feel free to call me SJ. Um, I am a leader for the Divergence database project, which seeks to create community and clinician validated interventions via digital platforms to improve access to competent and affirming intersex care. I'm currently conducting a multi-phase research study to incorporate expertise and perspectives from community members and clinicians into tool that I'm developing and validating. And the inspiration for like kind of my work so far comes from a patient advocacy network that I started when I was 18, shortly after I had been diagnosed with an intersex variation, which has now reached over 300 intersex individuals hoping to find affirming care. And all of this work would really not be possible without the support of Dr. Dalke, who I met, I believe, when I was 19, via sending her this kind of email just saying that I wanted to really make a difference in intersex healthcare. And along the way, Dr. Dalke and a number of really amazing people have supported my work and have really opened my eyes to so many new opportunities. So I feel very, very lucky and grateful people in my life. I guess like to kind of talk about that a little bit more, one thing that I feel very excited about and that is going well and is always a high of my work is being able to just meet and collaborate with so many passionate people who I really didn't expect. I didn't expect that so many people would feel so invested and so passionate um, about improving intersex healthcare. Yeah, um, so that's kind of it. Yeah.
Glad to hear it, SJ. And also for everyone here, this is SJ's first panel as an expert. So make sure to give an extra round of applause for SJ for joining us and sharing his voice today. Uh, all right. Next on my list, I'm going to talk to Bonnie and like to ask you to introduce yourself, say a little bit about your work in intersex health and something that's going well.
Great. Hi. Thank you so much for having me. My name's Bonnie Scranton. I'm coming to you from the Hartford, Connecticut area. My pronouns are she, her. Currently working a bunch of different places, but most recently, I took a role as an assistant professor in the social work department at Central Connecticut State University. And I also work at Connecticut Children's Medical Center as a family support clinician. And I'm hoping to be able to talk a little bit more about even what that is and what that means. I think, my connection to ADOS is really through, I did my doctoral work in clinical social work at SP2 at the University of Pennsylvania. And last year did a LEA fellowship and a postdoctoral fellowship at Children's Hospital of Philadelphia. I think I think what's going well right now is an event like this, but also there have been a number of opportunities in the past 2 years, really, sort of like SJ was saying, more people seem to be interested in learning more, and there are more sort of interdisciplinary opportunities to, first of all, have social work kind of take its, like not exactly rightful place, but sort of its appropriate place in the care of people with variations. So that's going well. And got a number of projects in the works, just at various stages of completion. But I think just that, again, that there's interest and that there are more and more opportunities to get the word out and collaborate with people in different disciplines. So, yeah, I think that's it for now. Thank you.
Yes, thank you, Bonnie. There will be more later. Don't worry, I have some questions about your dissertation and some of your work. But next, I'm going to ask Kimberly to introduce herself and say a little bit about what's going well right now.
Hi, yes, great. Hi, everyone. It's really nice to be here. Yeah, so my name's Kimberly Zieselman, she, her pronouns. I am an intersex woman. I was born with complete androgen insensitivity syndrome. That's my intersex trait. But I didn't find out the truth about my body or what had been done to me as a child, surgeries, until I was 40. So I came to this movement rather late in life. And it's really interesting, Katie, to reflect back because I think you know this. You were one of the first people I met, and how I met you was by watching a video clip of Oprah and you and your mom being on Oprah speaking out back in, I think it was like 2007. And this was a few years later that I discovered the truth, got online, also got connected with peer support using those old listservs. And that was absolutely life-changing. And I found support. And that was the focus for me. Meanwhile, I had gone to law school and I was working in healthcare policy. Interestingly, for Boston Children's Hospital, which is a hospital that cares for intersex children and doesn't always get it right. And I was doing advocacy work and government relations work for them, having no idea that upstairs kids were getting intersex surgeries and having no idea that I was intersex. So the world works in mysterious ways. But I found the support group and then decided I was ready to get involved in advocacy. And I started working for Advocates for Informed Choice, which I became executive director of, and then we later rebrand to Interact, Advocates for Intersex Youth. And I was there for about 8 years, focusing mostly on intersex health advocacy and youth development and visibility raising in the United States. Then I had an opportunity to join the Biden administration at the State Department, working with Special Envoy Jessica Stern as a senior advisor on LGBTQI plus human rights. So did a little over a year and a half in Washington, focused on global intersex rights, and now am at Outright International, where I've been for a couple of years as senior advisor for global intersex rights. Um, what is going well? I would say right now, the first thing that comes to mind is because I'm very busy with it, is myself and colleagues and some global intersex activists from around the world are very busy planning the very first ever intersex side event within UN headquarters in New York. They have side events have existed, have happened in the past in Geneva, but this is the first time it's happening in New York. So we're trying to bridge the gap. Around some positive developments that have happened at the Human Rights Council at an international level in Geneva and bring it to New York for the UN there. And so that's pretty exciting to be working on that. We're going to be lifting up the voices of some amazing, diverse global activists. Um, and that will be coming up in just a couple of weeks on March 18th. So yeah, that is the focus for me at the moment.
That sounds great. March 18th, everyone, mark your calendars. And I will also say, if you've not opened the chat yet, presenters, getting some nice comments and feedback there, dropping peer groups that you've used or recognized, events that you're interested in, letting folks know that way would be a great way to do it. So thank you all for introducing yourselves. And as I mentioned during my opening, one of the things we really tried to get to do at ADOS is bring people who are kind of engaging with the same populations, but from different perspectives to kind of compare how it looks. So I want to kind of drill down on some of your professional experiences to understand sort of what your field and sector are and some things that have happened there. And we're going to go in reverse order this time. So Kimberly, you're back up. You mentioned in your answer that you worked with the Biden administration on the first ever HHS report on intersex health equity. So applause for that. But I'm wondering, can you tell us more what that process was like in making that report, working with the government in that way, and also sort of what the significance of the report was after it was released?
Sure. So before I was in the Biden administration, I was at Interact, and Interact was collaborating with the White House soon after the Biden administration started, and we're instrumental really in developing the first what the White House calls listening sessions, specifically for intersex people across the U.S. Because of COVID, this was done virtually. Unfortunately, we weren't in the White House, but it was really significant because a number of people, intersex people from across the United States, were able to share their stories and actually, for the first time, really feel like they were being heard by the US government and, in fact, the White House. So that was significant. And then I think it was June of 2022, during Pride, during a White House Pride celebration that President Biden and Vice President Harris were holding, I was there with a couple of other intersex activists, and it was the first time, first of all, that we had ever heard a president actually include the I in the acronym and say the word intersex. So that was a pretty historic moment. I mean, this is where our movement was just back in 2022, in some ways still is, with just having a president understand or at least say the word intersex was pretty big. And then he announced an executive order that addressed a number of LGBTQI health issues, including mandating Health and Human Services, the Department of Health and Human Services, to do research and issue a report on the intersex health inequities in the United States. So that was really, honestly, groundbreaking that there was going to be, and that there is now, an intersex health report. First time anything like this had been done by the US government. So several months after that, I joined the Biden administration, and I happened to join in October, just like a week before Intersex Awareness Day, when Assistant Secretary Admiral Levine, Rachel Levine, was HHS Assistant Secretary, was hosting an in-person, hybrid actually, listening session. So I was able to participate in person and got to know some of her staff. And because I was an out intersex person working in the Biden administration, even though I was at the State Department focused on foreign policy, I was able to collaborate a little bit and advise and connect with the amazing folks at HHS who were doing this work. Uh, the person who I got to know, and I know some of you on this call also know Adrian, was Adrian Schenker, was working with Rachel Levine, doing a lot of LGBTQI plus policy work, but was the coordinator, was the main contact for this report. And a lot of his commitment as an ally and public health expertise is really why and how this report actually eventually got done. He now has a consulting agency called Schenker Strategies. He's a brilliant healthcare policy nonprofit. Shout out to Adrian. Um, so the process, continued of gathering stakeholder feedback. I know Katie, Bonnie, I think a lot of parents, providers, certainly intersex people provided input in a very formal process. There was a huge lit review. Um, and then months of analysis and drafting. And then, of course, some politics comes into play, right? So this report was supposed to be presented to the White House about a year later, so June 2023. And for a variety of reasons that I don't fully understand, but have a sense it had a little bit to do with the pending election and, quite honestly, the trans push during the election by the right, um, I think made people a little concerned about putting out a report that was going to mention children and genitals, quite frankly, even though it is very different than transgender. But the good news is, it didn't come out when it was supposed to, and we were very nervous that it was never going to make it because of this, and that would have been crushing. But after the 2024 election, on the last day, full day of the Biden administration, the report was released and put up on the website. So we now have advancing health equity for intersex individuals. It went up on the HHS website. It was, for many of us, a huge relief and celebration. And I have to say, our enthusiasm in our party got cut short because on Monday, President Trump was inaugurated and issued one of many executive orders, but the one that tried to define sex, erased trans people and erased many intersex people, including myself. And then, of course, days later, the report was taken down off the HHS website. But the report does exist, and it exists in various places, including Interact's website, and I can add the link in the chat in a minute. It was the first ever report to provide really a roadmap for what they refer to as a whole of society approach to advance health equity for intersex individuals, bringing together policymakers, healthcare providers, parents, families, intersex advocates, of course. And it also aimed to, I think, increase awareness among healthcare providers and the community generally, because there still obviously is, unfortunately, still a lack of awareness and understanding about our community and what our key issues are and what makes us unique, perhaps, from others in the rainbow community, even. It clearly states that achieving health equity for intersex people across the lifespan is the goal, and it will require partnership and outreach, in various forms, to be able to eventually change practice and or laws and policies as necessary. It's it's an important report. It's speaking to the realities of roughly 5 million Americans. I mean, as you said, intersex is as common as red hair or more common than the birth of identical twins. It's not as rare as people think, yet there have been huge gaps in our understanding our healthcare needs. Um, the report did a lot of things. I could go on and on, but in the interest of time, it did make some recommendations and offered some guiding principles that I think are still really important for public health and healthcare in general around things like protecting the rights of intersex people, but also affirming and supporting parents and the roles of parents in this process, promoting bodily autonomy, informed consent, things like that. So I think the takeaway here is that this report was groundbreaking. It didn't quite get the attention it deserved because of when it came out and the change of administration. But it's still a valid resource and available to everyone. And so I will put a link in the chat and always open to more questions about that.
Thank you so much, Kimberly. Yes, there's hunger in the chat for the
Oh,
links. So if you
I
get a
can't do both.
chance,
Okay,
no, it's fine.
I'll do it
No,
now.
thank you for that. And again, thinking about sector work, that working with the government can take a long time, requires a lot of people being involved, so it can be very slow. And of course, it's susceptible to the winds of change. So again, in thinking of how some of your work has happened, that's an important context to understand about that. I'm going to ask Bonnie to go next to talk a little bit about your dissertation and your research work, to talk about sort of what is the academic route that some of this work can take, and specifically also not just working with intersex people, but with their parents. So would you mind telling us a little bit about your dissertation?
Sure, thank you. Also, just to contextualize it a little bit, what I failed to mention is that my initial kind of connection with the intersex community came in 2014. My eldest child was diagnosed with an intersex variation, and I spent about 10 years trying to educate myself about how I could be the best parent, how I could be the best advocate, the best ally. And there was really not a lot of development of the focus on psychosocial care from, probably I'd say the late 90s until about, 2018, maybe. There was a lot of talk about it. And the major advances were that finally we got some major institutions like medicine, psychology to acknowledge and to sort of substantiate that people with intersex variations were actually really in need of competent psychosocial care as well as competent medical care. But yet that was still sort of a directions for further research in most people's papers. So that was sort of like the parting gift of, someone should be doing this, someone should look into it. So I think I really became frustrated, really. And that was the impetus to go back to school, excuse me, because during COVID, I thought, well, somebody should do something about this. And I kind of had been looking around for years thinking someone's going to define this. Someone's going to say, what is psychosocial care for children and their families? Who's responsible for doing it? How do they learn what they're supposed to do? Where should we deliver this? What should we deliver? There were just so many questions. And I knew that I wasn't going to be able to delve into that, in the privacy of my own attic during COVID, because I knew that I would need, sort of institutional support. I needed to learn more about how to do this kind of work. So the dissertation was really the drive, that project was really the driver for why I went back to school in the first place. And I guess the things I really want to emphasize is that it was really a combination of both, the content of what I sort of was able to sort of amplify, and then sort of how we did it. So I think the idea is that we always have known, is well substantiated, well documented in the literature. Like I said, that people have been harmed, as Katie was referring to, by medicine, and also by psychosocial mental health care. We know that, and we don't need to reinvent that wheel, but we do need to start listening to people who have been talking about this for years and years and years. We also know that the psychosocial support has been broadly supported with other things that I think intersex can kind of be a little bit in the center of a Venn diagram. So, we have something like the Family Acceptance Project, which is sort of broadly accepted as something that, or broadly, esteemed as a real groundbreaking idea. We've got pediatric, medical parental stress models. So we've got a lot of literature, but nothing that really targeted this group. So I felt really strongly about that we should not. I really wanted to depart from sort of this idea of damage-centered research, where we just sort of we sort of reinvigorate, the harm. And I really wanted to capitalize on people who had benefited from psychosocial support to find out from them, what has worked, both from a parental perspective, but also I did 22 interviews, 11 with parents, sort of veteran parents of children with variations. And I define that as, people who had sort of been in this understanding of their child for more than 4 years. And then I interviewed 11 adults with variations because I really wanted to learn from them both what their experiences of support were for themselves, but also where they felt like the high points were in their upbringings, for those who had earlier advanced knowledge, but then also what their relationships were like with their parents, like even in the case of, like Kimberly's story, learning later in life. Because, if we have parents, we're still a child and they're still our parents. So this is sort of over the lifespan from prenatal all the way into adult. So I really wanted to figure out what was working for people and then working together. This was sort of the most important aspect, I think, that this was really it was not a big enough, long enough, longitudinal project to say really it wasn't exactly a community-based participatory research project by those definitions, but it was very much co-created with community members. I had a council of involved people who've been in the community for years, who really sat down with me after I sort of took my qualitative data, ran it through the phenomenological ringer, and then we had several meetings to try to figure out, what are the things that would be really appropriate, really needed, and what would be the best ways to develop that. So I definitely won't get into it here, but I used a health promotion framework called intervention mapping to do some of that work. And then, like I said, we had several meetings to come up with things that we thought would address some of the major hurdles that families have. And so some of that was from my own experience of knowing that there was so much wisdom in the community that was untapped, mostly because people in academia or medicine or politics or, other kind of power structures were really not open as much to listening. But the other piece was that I really felt strongly that that wisdom needed to translate for people who are very new to this. So, I often say, like, nobody's really born an advocate. We sort of have to get our sea legs. We have to kind of understand what's going on first. And for many, many families, many people that I've worked with in the community space, also in sort of the more medical spaces, just often don't have the language even to have any understanding of what's going on. So they're already at this grave disadvantage to even be able to make their own meaning. So I feel like social work kind of already has that mindset. And sort of like Kimberly was saying, the world works in mysterious ways. I was already a social worker, already working in this sort of sex and gender space, and felt quite, I guess, not shocked, but also pretty ready for this parenting thing. And I had the benefit of already knowing my child for 14 years. So that really helped. But, not everybody has that experience. So when someone gets a prenatal, piece of information, or they give birth and they don't even know their child yet, there's a lot going on in terms of trying to understand what's happening. So I feel like the bar to entry has to be pretty low. It has to be pretty easy to get information. And so I'll talk about that later. But I think even with the project, we really talked a little bit about how people need to have support. I don't want to say passively, but almost receptively before they really want to take this step into a space where they have to, meet someone, speak about it. People often don't know what even questions to ask. So I think, but the one thing that came out of the two things, and then I'll finish. The one thing that came up with that I wasn't expecting, but also wasn't surprising, was that people said a lot about how meeting other people of different ages and stages of life was so healing. So I've sort of working on, a paper sort of about the intergenerational healing that can happen in support spaces. But the other thing, hands down, and Katie and Kimberly have sort of talked about this already, but meeting someone else, connecting with someone else. I knew that people were going to talk about that, but what I didn't expect was for parents to say, and this was 201, and this was not in response to a direct question that I asked, was I didn't know how much I needed this until I experienced it. And then that's when I realized how isolated and alone I was feeling. And it just transformed everything. So I sort of had known that support was important and meeting people was important because I had had that experience as a parent. But operationalizing that in a psychosocial intervention is tricky. So we did it. And I can talk about that more, but I want to leave time for other people. So thank you so much.
No, thank you, Bonnie. Again, I appreciate again thinking about how academics are able to engage in these deep conversations and get data from a wide set of people, but there's still that struggle to get that out and disseminate it throughout the entire other field. So it's really a great way of looking at what the advantages are and sort of what still needs to get done. SJ, I'm going to talk to you next. Now, you have been working on a novel solution to address intersex health with the Divergence database. And I'm curious, what encouraged you to kind of create your own offering?
Yeah, I guess it was a bit of like a long and winding road to get to the point where I was thinking of creating like a tool or intervention. Um, I
Well,
guess to
first,
give a
tell us
bit
a
of
little,
a,
sorry, I'm gonna
oh,
interrupt. Tell us
sorry.
a little bit what the intervention is, and then tell us
Oh,
sort of
okay,
about
yeah,
your
sorry.
start.
So essentially, the idea of Divergence database is to create a kind of a dual facing platform where there are clinician decision support tools as well as resources for patients all on the same platform. The idea of this is to address two sort of like big barriers in intersex care. One is competency of care, especially on the primary and secondary care levels. And the second is access to care, both of which are very limiting for many intersex people, especially for individuals who are transitioning from pediatric to adult care. Um, so the idea of this tool essentially is to create this kind of bridge that allows who are interested in and passionate about providing intersex care, especially primary care clinicians, um, you know, nurse practitioners, family doctors, as well as secondary care specialists that exist for a local community, such as a town's endocrinologist or a urologist that takes patients from a certain region who are not based at sort of like tertiary care academic centers to also be able to provide longitudinal care for intersex individuals. So that's where this tool kind of comes in. The reason why I felt like a tool like this was important to sort of develop and validate is because largely based on a combination of my own experiences. Oh, am I cutting out? Um,
I think you did come out once for me, but it's back and it's been good for a while.
okay, all right. Yeah, sorry. So essentially, it kind of came from a combination of my own experiences and community experiences, where it took me about 5 years from when I was 13 to when I was 18 to actually receive a concrete diagnosis. And then after that, another, I would say almost 2 years to get transferred to a multidisciplinary care clinic. A lot of that information was completely obscure to me as to how this process was supposed to work. And a lot of my ability to even access sort of like the multidisciplinary care model, which had been kind of elevated in the 2006 Chicago consensus as, the way forward for intersex care, was very difficult to really access for, I think, for anybody, for a young person looking for care, for families looking to refer their children. And then, at the same time, I was um, in a lot of communities, I was talking to other intersex people, and I found that I was actually one of the lucky ones who actually managed to get a referral to a multidisciplinary care clinic. Many folks were unable to access that because of insurance coverage, because of location, because there was usually only one multidisciplinary care clinic in a single state or in a single province. Um, a lot of folks had aged out of the pediatric care system and therefore had no way to access a diagnosis. And without a diagnosis, they had no way of accessing any sort of specialty care. A lot of folks had transitioned out of the pediatric care system into the adult care system where they had no access to a physician who knew anything about their diagnosis, they had no ability to even continue a treatment plan that had been created for them when they were still in pediatrics. So I began to see a lot of issues for access to affirming and competent care. And that kind of snowballed into founding a patient advocacy network with two of my friends from the community. And then that led to meeting Dr. Dalke. And then that led to, the formation of the Divergence database project, getting a grant to create the project, validate it with clinicians. So I work with clinicians at Boston Children's Hospital and Leary's to incorporate their expertise as clinicians at the multidisciplinary care level, as well as community members regarding their healthcare experiences to create a tool that's going to be the most useful and the most relevant to help people access care, for clinicians to feel that there's less of a gap in terms of approaching the kind of intersex care field to be able to more easily conduct kind of like diagnostics, assessments, and to have a referral network that will allow them to connect with other clinicians who are also passionate and competent providers in this field. And so that is that's kind of the work, and that's kind of how I got into it.
Yeah. No, it's amazing to think of when you're creating something new, how many people are involved. Something I'll encourage you to do, SJ, while I talk to Katie in a second, is if you want to drop a link to either the advocacy group you mentioned founding with some of you, people you worked with, or any information online that people can read more about the Divergence database. There's some questions about that in the chat. So anything you'd like to share, please use that. And while you do that, SJ, Katie, you're on board now. So we've talked about kind of different sectors people are involved in here. Obviously, you're involved in medicine. So I'm kind of going to ask you, how can doctors best support their intersex patients now at the moment?
Yeah, I think that is in a lot of ways, that's the most important question in medicine, and it's a surprisingly difficult question to answer. Um, and I think what helps me think about this and understand why that question is so hard is to recognize that intersex people within the world of health research fall at the intersection of a minoritized population and rare diseases. And the research methodologies that we use to understand the experiences of minoritized populations and people with rare diseases are very, very, very different, right? So if you're studying, for example, patients with cystic fibrosis, you enroll as many people with a specific form of cystic fibrosis from as many multi-specialty centers in the country as possible and collect as much clinical data as you can. And there's a lot of really valuable information that's gleaned from that. If, on the other hand, you want to understand the health outcomes of second generation Latin American Americans, you tend to do more survey data and more population level studies to understand what's happening. What's really interesting in the world of intersex health is that when you look within medicine, the vast majority of the literature we have comes from that rare disease model. And we're just starting to get population health research. And the quality of both is really limited for different reasons. I think the quality of population health research is really limited because we don't have, for example, like validated measures to be able to identify people who are intersex within given populations. Because a lot of folks who have intersex variations may not know that they have intersex variations or recognize that that's what's going on in that language, may not participate or choose to participate in a study. Um, so we tend to see actually in population level studies an overrepresentation actually of, not to put just Kimberly on blast, but people like me and Kimberly, like particularly white women with androgen and sensitivity syndrome are by far the most overrepresented group in those population studies when we're actually a relative minority of people with intersex variations. On the biomedical research side and the like sort of the health sciences research, there's certainly a lot that you miss about people's social experiences and structural experiences when you're approaching things from a clinical lens. But there's also, and this is what Bonnie was speaking to, there's a lot you miss about people's psychosocial experiences. So a lot of these studies will be looking at a single population of people with a single intersex variation in a single clinic, and they will ask people about their mental health. But then there isn't enough, the population isn't big enough, or the approach to those questions isn't designed really to pull out this nuance in what people need in the non-medical aspects of their care. So I think what that means is that, like, we are still flying relatively blind when it comes to providing excellent care for folks with intersex variations. I really, I really loved the language that excuse me, that's someone in Bonnie's family. I really loved the language that Bonnie used around wisdom. And I do think that like there is a lot of wisdom within the intersex community, but also within people who have been taking care of us for a long time around what does help. And in general, what we tend to know is helpful are things that seem very simple, but are actually very challenging to do when you're sitting with someone where there's a lot of uncertainty, there's a lot of stigma, and there's a lot of stress, which is to slow down, turn the temperature down, ask more questions than you're answering, really listen to people and try to meet them where they are and figure out what they need at that particular moment in time. There are some frameworks that, in general, actually mental health professionals like Bonnie and myself tend to be more comfortable with than non-mental health medical professionals, like trauma-informed care, for example, that seem to make a really, really big difference, even in the absence of what we might think of as like a capital T trauma. But I think in my work with healthcare professionals, one of the things that continuously humbles me is that we got to this problem of people with intersex variations being harmed by their medical care because of good intentions, right? Like people were trying to protect us from stigma. They were trying to protect us from being isolated, from being shunned, from not being able to have long-term romantic relationships or have children or be able to sustain employment. Like these were all things people were really trying to help us with. And I think where we are now is like the missed opportunities are still because of good intentions. It's because of this sense of like, well, you're coming to me to help you. So therefore, I'm the one who should have the answers. But like, we really don't have the answers. And so I think really a lot of what I talk to clinicians about is about humility and curiosity. People who are in health professions, especially in medicine, are people who love expertise and who love feeling competent. Humans in general like to feel competent. Um, and it's just really, the more I've done this, the more compassion I've developed for people who are in these situations where it is very, very difficult to achieve competence because of how little we know, and also how infrequently even people who see a lot of folks with intersex variations actually treat people with intersex variations.
Yeah. I actually love the arc there from sort of acknowledging what is unknown and then embracing the humility and curiosity around that being a good catch-all in the absence of not of concrete knowledge that I know doctors and providers really want. So thank you for that, all of my panelists. I do want to kind of broaden the conversation now to kind of throw some general questions for you all to respond to, and feel free to talk to each other. Um, I wanted to start with sort of like, what do any of you see as like the most pressing needs in intersex health right now? Like, what are sort of the top things that keep you up? Bonnie was the first to unmute, so Bonnie goes first, then Katie.
I only unmuted because everyone else was already unmuted. I guess I just want to pick up on to answer that. I guess I'll pick up on something Katie just said, which is that I think this is part of the strength of the interdisciplinary potentially model. And also just to honor what SJ was saying, I think the access to this sort of multidisciplinary, interdisciplinary care is so limited. And the transition to adult care is really problematic. I am proud to say that where I work, we never kick anyone out. We'll like see you until however old you want to, however old you can get. But I think that might be sort of on the unique side. But I think part of the interdisciplinary with someone from mental health is that, as Katie was saying, we are a little bit more comfortable with the not knowing. So I always sort of, I don't know, guess kind of like rib my medical colleagues a little bit to say, you are supposed to be experts. People come to physicians because they want you to know things. And like my superpower is to be comfortable sitting with not knowing something. So like holding some just like space for people to grow into who they're going to be, and also to just sit with parents and say, we're just going to have to we're going to have to wait and see, like let's just focus on what's happening right now. And I'm pretty comfortable, like that is what we're trained to do, right, is to sit with uncertainty and help other people do that. So I think that's one thing. I think a big challenge or a most pressing need would be to figure out where we belong in terms of intersex care or care for people with variations. I think systems tend to have structures, they tend to have money, they tend to have resources, they tend to have networks. But I think a lot of times our work falls betwixt and between. We're not enough this, we're too much that, we're not enough this. And so I think community space has been the place where I felt is the most fruitful. When I sat down to think about how my project was going to take shape or what it even was going to be, I kept thinking to myself, the best things that happened for us as a family and for my daughter as a human being, none of that happened in a hospital. Like none of it happened inside the walls of a medical establishment. And so I kind of just trusted my gut on that to think about that. But the reality is that, again, resources, infrastructure comes with institutions. So how do you sort of almost like decolonize or deinstitutionalize care when that's where the resources are? So I think that's tricky.
Yeah, Bonnie, I so strongly resonate with what you're saying. And this is something that SJ and I actually have been talking about a lot, which is that like even within medicine and healthcare, part of what we're trying to do is to demedicalize the approach to these variations. But to do that, you have to work from within a medical framework. And that's a really like sticky and difficult problem, right? It reminds me of that Audre Lorde quote that you can never dismantle the master's house with the master's tools, right? But actually, I do think SJ is figuring out a way to do that, not to like, put the whole weight of the world on their shoulders. But I think as I think about the most pressing things to me, and this is, I think is something that um, I give a lot of credit to Kimberly and her work as the ED of what's now Interact for doing, is really thinking very intentionally about coalition building. And I say coalition building both in the advocacy movement context of developing relationships with other groups for whom we have shared interests, right? So, Kimberly mentioned Adrian Shanker before. There are a number of other LGBTQ health advocates and activists like Adrian, um, uh, who, like Harper Jean Tobin is another person who comes to mind, who are not part of our community, but who recognize that the things that matter to us also matter to their groups and also matter to other groups. And that has been hugely important. I'm also talking, though, about coalition building, like even within our community. I think we still struggle to um, recognize that what's good for parents is also what's good for children, is also what's good for adults. And so I think there's a lot of work for us to do there. And then I think in particular within the health professions, to me, one of the most impactful things that we can do long term to advance our healthcare is to help non-specialist providers understand that we need them also, right? That like intersex healthcare is also primary care, is routine reproductive care, is routine endocrinologic care or musculoskeletal care or sports medicine or whatever it is. I think we still, part of the reason we have so much trouble accessing healthcare is because there's the way this is trained is in this very hyper specialized model. So the way that I would kind of, again, sum that all up is to say, I think the most pressing need is to get as many different groups of people as possible to recognize that these issues are not like they're special, but they're not that special. And they really do matter to and serve a lot of other groups.
Yeah, thank you for that, Katie. And Bonnie, I mean, everything you're saying is, of course, resonating with me as well. Um, I mean, I guess my thought when you asked this question sort of fell into two camps. Something that Bonnie's alluded to a little bit is just the lack of resources. I mean, having been doing this work as an activist, for the number of years I've been doing it, that is a constant and actually increasingly difficult problem lately. Whether we're talking about research or whether we're talking about new medical curriculum and trainings or whether we're talking about funding sensitization efforts of lawmakers. There are very few resources. I think less than 1% of the resources that go to the LGBTQI plus movement go to intersex work. And the LGBTQI plus movement is already underfunded. So just, we're talking about a tiny amount of money, which is also why we need those institutions. And this is the tricky balance. We need institutions with resources, and I think we need to think more broadly and out of the box around the institutions. To your point, Katie, about like how like our issues aren't that unique. Like these are transferable and intersectional issues that we're talking about. I would love to see our movement from an advocacy perspective too be more collaborative with like the reproductive justice movement and the feminist movement space and disability rights. I mean, talk about a group of activists and communities, families, and people that have been there, done that around, pathologizing and parental rights and struggling with bodily autonomy and those tensions. I think we have a lot to learn from that movement as well. And of course, the children's rights movement. So I think this goes back though to the resources issue is that everybody is struggling, including all of those movements. So how do we get them invested in taking on or collaborating with us on yet another issue that they might see the intersections and the importance of, but everybody's really kind of it's survival of the fittest right now, especially with recent cuts around like, just resources and capacity. Um, the other thing that pops to mind is visibility and education, and it sounds so basic, but I don't think we are going to effectively change medical practice or laws and policies to advance intersex rights and intersex well-being without a broader, general, mainstream understanding that intersex people are just a natural variation of life and what our key issues are, and we are the neighbor next door or the person up, checking you out at the grocery store. I think that's why I have this, my day job is policy, but my passion is side projects around raising awareness, whether it's through books, films, theater, um, podcasts. I mean, I think we need all the things to infiltrate because until we do that, we're not going to be able to move the needle, I think, and certainly not fast enough. So I think those are also ways that all of you can help. I think these are ways that people can get involved just simply by sharing information and, talking about it, sharing a book you read or a film, or just having a conversation on a Friday night over dinner, being like, hey, you know what I learned today? I think all of those little things go a long way. And I'll end with, we also need, we need intersex as an actual variation and a possibility, not as a social or medical emergency, to be included in things like, I'm probably dating myself right now, but that book, What to Expect When You're Expecting. Why isn't it in there yet? It's 2026. So I don't think that's rocket science. So I think there are some things, again, with resources and capacity that can be done.
Thank you so
Yeah.
much for,
I,
yeah,
I Oh, sorry, did I interrupt? Yeah, I agree with your point a lot, Kimberly. Just like the idea of like resources, the idea of like thinking of intersex as a natural variation, because I think a big barrier to care access is that a lot of providers are very daunted by the idea of working with an intersex person. I think Dr. Dog kind of touched upon this as well, but I think the more that people conceptualize intersex bodies as alien, as something very difficult to understand, very different from the norm, the more there will be, I think, this kind of like upwards upwards shedding of responsibility. And when I say that, I mean that people will say, I'm not equipped to deal with you, right? I'm not equipped to address your issues because I don't have the expertise. And they will say, I'm going to refer to someone who knows more. And then that person's going to say, I'm going to refer to someone who knows more. And then you get this kind of like this never-ending cycle of referrals to people who feel that they are not confident enough to be the provider for this patient. And the patient may be approaching the provider for something as simple as a urinary tract infection, right? They may not need, hyper specialized care, but I think the more that I think the medical system and providers believe that this is like a very special category, that this is a very like unique category where everything about this person's body is different, the more that that kind of shifting of responsibility, due to kind of fear of doing the wrong thing, is going to be a major barrier, in people's ability to access even basic care. And I think I see this in real time with a lot of like multidisciplinary clinics where, providers do not, in those clinics, do not know where they can, refer people to once they age out of the clinic, right? And that leads to, you know, the clinic keeping folks for a very long time, which I think is very kind of these multidisciplinary clinics, but it also means that these clinics are very overburdened by their patient cases. New patients have a hard time getting into these clinics because they're already full in terms of their rosters. And then, I'm sure that many patients are also nervous about, during that life transition phase of, becoming an adult, graduating from university, if they move to a new city for work, for school, for, you know, whatever new opportunities come their way, are they going to lose access, to their care? And that is a real concern for people who are embedded in, the pediatric system at the moment. And then for folks who, you know, were not able to access that system, which is very common in individuals from lower socioeconomic status, individuals from immigrant backgrounds, who I think, as Dr. Dalke mentioned, are maybe have parents who are less medically literate, you know, don't have access to a knowledgeable pediatrician. Those people, you know, kind of fall through the cracks, of the pediatric care system. They enter the adult care system with no diagnosis, and they're stuck in this vicious cycle of, this is a pediatric diagnosis that I know nothing about, so I'm going to refer you to someone who may know more. And then they have many, many sort of, I guess you could say, basic or simple care concerns, such as, you know, like reproductive health checkups, um, you know, like urinary tract infections, even mental health concerns that go unchecked and unmanaged for years on end, due to that sense of, kind of that sense that people are daunted by working with an intersex person. And so I think in some ways normalization and demedicalization also has the ability to actually make medical care more accessible, to the intersex population, despite that feeling like almost on the surface it's a like contradictory notion that demedicalization can enable sort of more accessible or widely accessible medical care.
Thank you so much for
Kevin,
that.
can I say one quick thing before we break into the groups?
Sure.
SJ I think just said something really, really critical about this sort of diffusion of responsibility or feeling like I need to be more expert before I can actually care for someone in my discipline. The effect that that has on parents is profound. It's never spoken, but it's implied because if you go to a person who you hope will be expert and they don't feel expert, as a parent, you feel like, well, then I can't possibly know how to parent this child because I don't know enough. And so there's this sort of domino effect. And I just wanted to share kind of like on an up note from one of my participants who said, I was worried about not having what I needed to be a good parent to my child. And they said, and then I learned over time that all I really needed to have for my child was love and snacks. And that's really all any of us need. And so I think, it kind of like Katie was saying, kind of slows it down, gives people a feeling of competency, and we'll all figure this out together. But when there's this idea of expertise, I think that can be very scary.
And urgency too.
And
And
yes,
urgency.
yes, right, exactly. Thank you for bringing that up.
All right. So we are at time. We're actually over time. So before I do my next thing, panelists, are you okay just for some 3 or 4 more minutes talking with folks? Okay, very good. So I'm going to wrap up our sort of panel section of the talk today. Thank you all so much for being here and joining us.